Okay, we'll go ahead and get started. Hi, everybody. This is the case discussion. A lot of you, how many of you, this is your first Ryan White Clinical Conference? All right, welcome, bravo. Yeah, welcome. It's good to have you. And for those of you who have been here before, you know that what I typically do are antiretroviral therapy cases with discussion from a panel. And these are questions that I get in our clinic, and from around the country, people might phone or whatever with a question. And I synthesize these in to try to see what we're dealing with in common scenarios. What's interesting is because I've done this so often, the questions are often the same as you might have heard before, but the answers are changing. And so that kind of makes it interesting. And to make the best use of our time, I've got the iPad up here. So if you have a question as we're going, send it on in and I can go in real time. That's one advantage of this technology. We're also going to have responses from you as we go through, so be ready to answer questions. There's about 8 or 10 of them as we go, and we'll get through this. So we have 55 minutes on the clock now, 54:04, so we'll quickly go down and introduce. I'm Mike Saag from UAB. I work at the 1917 clinic. Steve.
Yeah, Steve Johnson from the University of Colorado.
Jill Blumenthal, see, I knew I was that. Jill Blumenthal, UC San Diego, the Owen Clinic.
You all already met me, so.
Right.
Judy Levison, OBGYN at Baylor College of Medicine in Houston.
Previews of coming attractions.
Jason Farley, Johns Hopkins.
Beautiful. All right, let's get going. So disclosures are usually first. Let's see if we get this cooking. Yeah, there we go. You can, again, the learning objectives, we're going to go through a bunch of things. You can look at that on your own. So I'll organize this by the question and then present a case. So this orients you to where we're headed. So it's like, are we playing baseball, football, or soccer? What initial therapy should I use? So this is about a 48-year-old guy who presents newly diagnosed. His initial HIV RNA is 280,000, CD4 count 64, although the labs are normal. You actually have your genotype back already. It's wild type. No past medical history to speak of, normal renal function. He's ready to start therapy. So which of these regimens would you use? And the X means either TAF or TDF or FTC or 3TC, so you can pick your poison there. And then I think the rest is self-explanatory. Let's go ahead and vote. And I would have music normally, but we don't have music. So I'll think of a song and like, I want a new drug. How's that? Huey Lewis and the News, and you can play it to yourself. Yeah. Okay. And no, I'm not going to sing. I could sing. All right. Let's see where we are. All right. So the majority of folks went with answer 100%. That's important. Oh, it's not work. Oh, one person. Well, the one person who voted, please stand up. Or Slim Shady, please stand up.
One person.
Okay, we'll keep going. Let's just talk
10
about
people.
the answer. So who on the panel would have used the bictegravir? It looks like Jill, you've got your green light on. Yeah. Go
That's
ahead.
usually what I start with. It is easy. It is, small, discreet, very few side effects. I actually am surprised you had a genotype back. Usually we'll start TAF FTC bictegravir without even having a genotype back. So yeah.
Judy? Yeah, you agree. Who wants to take one of the other options? How about the TXF XTC dolutegravir? Steve?
Yeah, I mean, I think that's close to equivalent, but I think there is something a little magical about single tablet regimens. And then the 2-drug regimen, we weren't provided enough information. Dr. Spock mentioned yesterday about hepatitis B and things like that.
Right. Connie?
So my only caveat with the bictegravir regimen was if I was in a setting where I had to be concerned about treating somebody for tuberculosis.
Yeah. And go into that a little more because we probably won't cover that. So you're worried about drug interactions, and which would be the better choice in that setting?
The dolutegravir regimens.
Oh, okay. All right. Yeah. Jason, what do you think?
Yeah, no, I totally agree. I would just offer the caveat that viral load was greater than 100,000. So abacavir would be kind of off the table anyway.
Yep. And I think we're sort of leaning, as opposed to 10 years ago, maybe 12, I think we're sort of having other options than abacavir. What about just the dolutegravir 3TC? There's no mutations, the viral load's less than 500,000. The CD4 count is higher. Anybody think that's something worth doing? We've used that a fair amount. Yeah.
I think until I know a patient a little bit better, sometimes I want to make sure that I do indeed have, a higher barrier to resistance, and choosing that just maybe a little bit more nerve wracking in someone you don't know.
Yeah. If we think the person's going to be taking their medicines regularly, there's no M184V at baseline. That's the key thing. Or hepatitis B. You can't use the dolutegravir 3TC because the 3TC will become resistant. Okay. I think we've covered that. Let's move on. One thing that's new that you may not know about, the IAS-USA has published these drug resistance mutations for several decades now, and this is a new release as of about 2 weeks ago. So you can go to the website and download that. For the Slido to work, you've got to sign in using new code. Let's see. There it is. All right, so let's have everybody take about a 30-second break to Slido in. I always thought of this as Sluggo. Does anybody remember that from the Nancy cartoons from the, yeah. You're showing that you were born sometime in the 1960s if you know about Sluggo. So let's go ahead and QR code in.
Mike, the one thing that I would add is the F option of cabotegravir rilpivirine every 8 weeks. That is now becoming something that people, even naive, are interested in starting right away, as opposed to having to go on oral medications.
And you want to use it monthly for the first 2 injections, and then you can stretch it out, right? And there's been some discussion, I will get into this while people are Slidoing. What if somebody's very obese? Do you do every 2 months or 1 month? Yeah. Jason, what do you think?
So I think the data suggests that there could be an impact in someone who's very large, but ultimately it has not panned out that it would cause a therapeutic deficit.
Right. So I think we're waiting for a little bit more data. If you're wondering about that, it's just a PK issue of whether there's a tail. That is the drug levels start to drop because of volume of distribution. And I think you just may want to have that discussion as we go through. Okay. And then the other thing I want to mention, because it's one of your pretest questions, is that with cobicistat and with any integrase inhibitor, you will see about a 0.1 milligram per deciliter increase in serum creatinine like that. And you say, well, what is that? Is that GFR? No, it is not. Something that I didn't learn in medical school because it wasn't discovered at that time was the notion of enzymes, proteins in the proximal tubule that are responsible for moving creatinine from the bloodstream into the urine. It only does a little bit. And so GFR, true GFR, is actually estimated pretty well with serum creatinine, but it's off by that little bit. So these drugs like cobicistat has impact. If you look to the right here, cobicistat interferes with this enzyme called MATE1, like matey. So MATE1 interferes with this excretion of creatinine in the proximal tubule, and OCT2 does it is inhibited by dolutegravir, bictegravir in particular. And I remember that because that's my birthday. So yes, thank you. Happy birthday to me. Okay. So what regimen should I use as initial therapy 3 years from now? So it's a perfect follow-on, I think, to Connie's talk. Here's some of the things she talked about. So over 3 years, this is again the same guy. You see him summarized on the right. And would you stick with the standards that we were choosing, including the cabotegravir, or would you might go with assuming islatravir and lenacapavir are out, or maybe some broadly neutralizing antibody, or an implantable? Maybe you can put something in under the skin like progesterone has been used, and maybe it'll last every 12 months. This is hypothetical. Let's go ahead and vote. I guess this is where I need a new drug. So we're back to Huey Lewis. If you remember Back to the Future, so we'll ask Doc Brown and Marty McFly to weigh in here. And let's see if Slidoing. Oh boy, yeah, we got some, yeah. Hey, we can be taught. So most people are, going to pull a George Herbert Walker Bush and not going to change, not going to debt, going to stay the course. But how about Connie? What would you do here?
Well, I'm kind of intrigued by the whole concept of implantable antiretrovirals. I don't know if it'll be 3 years that we'll have enough data to make us feel comfortable about that, but I like that potential option. And I also like the sub-Q 6 month option.
It is kind of intriguing though, isn't it? Because we have proof of concept that injections
Right.
sort of overcome people missing doses, and implantable, unless they explant it, that could be cool. Steve, what do you think?
Well, I think the cabotegravir rilpivirine, there's still a lot of interest in the clinic in this, and it's had kind of a slow startup for logistical reasons more than patient interest. So I see that potentially being more common. And then if we're talking 3 years, the vexing issue right now in clinical practice with integrase is weight gain. So if there is, if our clinical trials do demonstrate alternative regimens that affect weight gain less, that could also be a change.
Given that I'm starting many people who are pregnant and newly diagnosed, what I would want to know is, were pregnant women included in the trials? Because one of our problems to date has been that the OBs are always a little bit behind because we just don't have the data, because the drugs are released before being tried on pregnant women.
Right, and that's always been an issue, and sort of with pediatric populations as well. Okay, I just thought I'd throw it out there. One of the other advantages, not that I'm really pushing this, just find it intriguing that if you inject a deep IM, then that drug's there, you can't get it out. An implantable can be removed, and it might take several days for the drug levels to drop, but at least you have some control over that. All right, this question came in yesterday. So I said we'd get to it, so here we go. Seems like we're starting ARV therapy for almost everyone. What about starting for a true, genuine elite controller? And what I mean by that is this kind of guy. 30-year-old guy diagnosed 7 years ago, is asymptomatic. His viral load has always been less than 50 off therapy, so much so that you want to confirm, and you got a DNA positive like you might do in diagnosing an infant. CD4 count's been stable at 870 for 7 years or thereabouts. Everything else is normal. You can see that there's no drug resistance mutations as best you can tell. And it's okay to start therapy if you want to. So are you going to recommend this for him? Yes, no, maybe? Go ahead and vote. So this is a bit of a conundrum. Trying to think of, what would be applicable. Maybe the Schrodinger equation, going back to chemistry, is a probability of him breaking through, and like a electron in an orbital, for a weird thought. Okay, 2/3 would definitely, it sounds like, recommend it, and a solid 14% not going to do it. Okay, so let's see, Jason, what do you think in this setting?
So shared decision-making, I would start there, because this is someone who's not urgently in need of ARVs. But I tend to weigh on an earlier start because of immune activation issues. And we know that despite having viral suppression, if we can ultimately, there you go, I read your mind. If we can ultimately obtain an undetectable viral load less than 20, the lower the viral load we can obtain, the less circulating cytokine activation and so on and so forth. And ultimately, the better this patient will do in the long run.
Yeah. Other thoughts, Steve?
Well, I agree with that. I also think this population is a little heterogeneous sometimes. There's true elite controllers, but then there's people with relatively low viral loads that still have kind of immune preservation. And I just think it makes sense to offer treatment. I really like the shared decision-making though, since especially
Yeah.
given some of the side effect issues that we're dealing with.
Right, Connie.
So Mike has a very nice slide with some older data, but I can't for the life of me remember where I recently saw it, but there's a study in elite controllers looking at T cell activation, and it looks just like that.
Right.
They do have immune activation.
Yeah, and this is another way of looking at it. This is
Yeah.
more specific data from Peter Hunt years ago, but that's kind of what drives my thinking. A question from the audience has a patient who's an elite controller, but is on renal dialysis. I wonder out loud whether that was renal failure caused by HIV. You know, HIV-AN is one of the most common causes, and it's usually from the virus replicating in the cells of the kidney. But in that case, it's kind of too late to save his kidney. But I think this is the point, that there's energy, there's effort that the immune system puts out to keep the virus under control. And in this case, it's working really well. And to me, it raises the question about the quote cure research that's looking for functional cure, that in essence is trying to induce a state of immune activation whereby the immune system controls the virus to give people drug-free holiday. I'm not sure that this is a holiday. This is more like a holiday out of Green Day with American Idiot. Yeah.
So
Go ahead, Connie.
maybe I'm misremembering it, but did you see this? It was a recent article on elite controllers and immune activation, and it actually showed that they had mortality rates, long-term mortality rates that were still higher than people who were HIV negative. So
Right.
even though it was low levels of immune activation, they were still not as well off as people who were not HIV infected.
Right.
And it may be, maybe I'm misremembering the data, but
Yeah.
that's
Yeah, and there was an older Air Force study too that showed that elite controllers were more likely to be hospitalized than people on ART and well controlled.
Yeah,
So again,
yeah.
getting back to that chronic inflammation.
so.
So
Obviously, it's not an urgent decision, and shared
Oh.
decision-making is
Right,
a
so-
critical issue, but.
So here's a question from the audience. Let's say you've decided, you think it's a pretty good idea, all things being equal, but the patient's a little hesitant. Jill, what would you say to that patient to kind of bring them along, or what would you do?
First of all, language matters, and I really don't want to call these people elite controllers anymore. I think we're trying to use long-term non-progressors. Is that correct?
Well, elite controller just means that the virus is totally
It's
undetectable.
very tough to call someone elite though, and everyone else is not elite, but I'll
Right.
work with this.
Right. In the
So-
South, we call them elite.
Yes, I like elite.
Yeah, we call them elite
Um,
controllers.
yeah.
Yeah,
have a-
down the block there.
I have a handful of patients where this has come up. I think it depends on so many things for them. One person that comes to mind is younger and really still can't, no matter how much we try to talk about the future, he can't really see it. And he says, I'm in this now. I don't need it now. He said to me, when you have long-acting injectables, I'll be on board for that. He's not doing those either.
Yeah.
So I think it depends so much on each person, what they're willing to do. How much are they willing to do? And what side effects are they willing to tolerate?
Right. And as we leave this topic, there is one thing that I think Peter Hunt's group and Steve Deeks and others showed, was that if you take, we don't use it much anymore, but the CD4 to CD8 ratio, remember that? If you divide it into quintiles, like 20%, 20% across, those who had the lowest CD4 to CD8 ratio among elite controllers, they have more early transition to non-elite status. So that's another little trick you could use if you're really on the fence, and if they have a very high CD4 to CD8 ratio, you might be okay waiting just epidemiologically. But all right, I think we've overstimulated here. Okay, let's go on. How do I manage blips? So this is again the same guy, just to make it easier. Like most of you, he got started on BIC, TAF, FTC, and he remained undetectable. Then suddenly we see him back, and this is a patient of mine, 91. Then I repeated it in a couple months just to see where it was going. It went up to 185. And then I checked it again about 6 weeks later, and it went up to 220. is this a blip? What is this? So he claims full adherence, and this guy is like an accountant or something, so you kind of believe him. Doesn't do intravenous drugs or anything. Which of the following is most likely the cause? So intermittent adherence, occasional recreational drug he's not telling me about, recent initiation of an MVI, de novo emergence of resistance, and interference. Go ahead and vote. Let's see. Is he lying to me or not fully revealing the truth? And then that gets like to, a few good men. Can you handle the truth? Maybe he thinks I can't handle it. Okay, let's go ahead and see what we got. All right, so 2/3 think it's an MVI as opposed to a CVA or something. So what do you all think? Yeah.
I already know the answer to this.
Sorry.
I've seen your question
Oh, okay,
before,
so you have to
so call on
abstain.
somebody else.
I know some of these, yeah. So Jason, what do you think?
Yeah, certainly. I mean, I tend to want to believe my patients, and I want to believe their stories in most
Right.
instances. So I would go with, I think an MVI is possible. It's certainly in this case.
Okay, Steve.
Yeah, I mean, we kind of, I'd call this more low-level viremia than a blip, just kind of given the numbers. But
Right.
I mean, adherence is an issue, resistance is possible. If it's a single value, we worry about laboratory error.
Right.
And we also learned from Silicano at this conference before that release of virus from latent reservoirs is another cause. But, we deal with this a lot in the clinic. I mean, this case is a little different because we see the viral load rising,
Yeah.
but we
Well-
deal a lot with blips and mostly we're reassuring. But if you look at studies of people who blip compared to people who don't blip, they do have a higher rate of failure.
Yeah, maybe the analogy I should have used was a television show Flipper, and he would be a blipper, but he's not because the blips usually come up and go back down. The MVI is a key thing here. And so I immediately got on the phone and said, have you started any new over-the-counter anything? And he goes, yeah, I started this multivitamin roughly about 2 months before he came in for his visit 4 months ago. I said, well, do you have it? He said, yeah. I said, why don't you read the ingredients to me? And it had magnesium, and it had aluminum, and it had a bunch of other divalent cations. And I went, aha. So why don't you stop that? Keep taking your medicine. And fortunately, this little bit of escape did not lead to emergence of integrase inhibitor resistance, and he resuppressed immediately. So just something to keep your eye on. That's the whole point of that question.
I have a question for you in this circumstance. With the new September DHHS guidelines showing that 220 copies needs a genotype, what do you think in that circumstance?
Well, if you can get it, I guess that might be okay. My strategy here was just to see if he resuppressed, and he did. If he didn't, I would have checked the genotype out of concern. But I think it's the reason why we typically say wait till the viral load gets to 500 or 1,000 is solely about the assay, right? And there's no harm in checking it, just that you often don't amplify in the commercial assay. But if you can get it, I just went that route. But it's a good point, Jason. How are we going to manage weight gain? So Roger was going to be on the panel, but I think folks here have seen this too. And the question is, what do you do about this? So this is a woman who got started on Big TAF FTC and had a lower viral load at baseline, came down nicely. CD4 count went up dramatically, but she also went going up pretty dramatically was her weight. So what are you going to do here? And I'm trying to think of a politically correct song that would go with this, and I'm not even going to go there. So you have to imagine your own song on this one. But are you going to keep her on the same regimen, switch her, get her off of the TAF, put her on something integrase inhibitor like option F or some other option? Go ahead and vote. All right. So most people, it's a big spread here. Jill, what would you do?
Well, and that's what the audience is correct. That's what the current DHHS guidelines show is that you would continue the current regimen. That being said, the person sitting in front of you may feel very differently about wanting to continue. I think the first thing you have to do is make sure there's nothing else going on. Any big lifestyle changes, there are a lot of other things that could be going on that you want to make sure that you address. But then, the two big considerations are both the TAF and the integrase inhibitor. And those are both things that you could consider removing and switching to another regimen like the D, so TDF, FTC, Dravarine.
Yeah. So those are good thoughts. So right now, the data that I'm aware of do not show that once that weight gain has happened, that switching does yet much, but there's an ACTG study that's evaluating, especially, I think it's Dravarine, and our co-chair in Dallas is helping to lead that study. Yeah, Judy, you have a comment? No? Connie?
I was just going to say, I think we're going to see some of the longer term switch studies showing some different data. So
Yeah.
it may take a while, but there may be a benefit to switching for people with weight gain. The other thing
Oh, sorry.
I noted about her, well, 2 points I wanted to make. One is almost every one of these studies that looks at weight gain before we ever had integrase strand transfer inhibitors or TAF, people who are treatment naive and start on antiretroviral therapy gain weight. And there's this phenomenon of return to health or stabilizing after you start antiretroviral therapy. And that may be an impact on reducing immune activation and some of the other things that might contribute to lower weight than what might have been the case if they weren't HIV infected. And the other point about Jill already made is that she's a 47-year-old woman. She may be going through menopause, and there's a weight gain that goes along with menopause as well. So there are probably multiple factors why this individual gained so much weight. And one of them might have been return to health, one might have been menopause, and then the impact of the integrase inhibitors.
I think the take home point at the end of the day is for everyone when we start therapy, regardless of what the regimen is, because you can see that all the regimens are associated with some weight gain over 6 to 12 months, is to just give everyone a heads up. Just be careful about that and make sure you're monitoring your diet. We want you to get back to feeling well. Among the integrase inhibitors, the dolutegravir, a little bit more than raltegravir or elvitegravir. But the cool thing to me is that most of that weight gain is in the first several weeks. So that's really the time to be especially mindful of the increases. I want to go back to some questions because I had moved on quickly. One question was challenging us a little bit on how are we so sure that antiretroviral therapy really does anything for an elite control? Are we just treating ourselves? Jill? Sure.
Well, maybe, but you showed the, really important data. I think that does suggest it's not just about us, although it does make us feel better.
Right.
The other thing about all of these studies that's always disturbed me is there's never an HIV uninfected control group
Right.
evaluated over the same, a control group in the same age range over the same period of time. And if you look at curves in the US population in terms of weight gain, you see fairly dramatic increases over time, depending on where you are in the country. So.
Right. And I think that's a good point. What was really cool was in the PrEP study, right, with cabotegravir, there was no difference in weight gain for the uninfected people getting it. Now there's maybe with more data, we're going to see something, but that was a surprise to me. And if Rafi Landovitz was here, we could get him to expand on that, but that is the closest thing I think we have, Connie, to what you were asking for. One comment from the audience I agree with is that once the viral load on a quote blip goes above 200, you got to worry whether it's really not a blip. Usually they're somewhere between 50 and 150, and then they usually come right back down.
Yeah, just one other point about the elite controllers. It's a fairly uncommon situation, number one, and kind of endpoints that you might use to kind of measure differences are very difficult. So I don't think we're ever going to have kind of the same body of knowledge that we have with other patient populations.
Right. One question here also, how much can we really blame on TAF? And I took a slide out. I thought I might have it there, but there is a pretty significant difference when people switch from a non-TAF to a TAF. Now, the question was, it was almost always going TDF to TAF. And some people are saying, well, maybe TDF suppresses appetite a little bit, so you just release them. So it's not 100% clear, but I think the data are reasonably good. It's not an enormous weight gain, but it is significant statistically. So what regimen should I use as initial therapy in a pregnant patient? And this is teed up right for Judy. So here we go. 30-year-old woman presents with newly diagnosed HIV, 6 weeks pregnant. Viral load, as you see, CD4. Other labs are normal, B5701 negative, wild type virus, no medical history other than her current first pregnancy, and is okay to start therapy if you recommend it. So what are you going to recommend? Go ahead and vote, and then we're going to have Judy walk us through this. Okay, let's see what the audience says. Oh, so the audience, for some reason, has jumped all over TAF, FTC, dolutegravir, and a fixed dose combination. Take it, Judy.
And I agree with the
All right,
majority.
and that's our discussion. No, I'm kidding. Please.
I think right now, for somebody who is ARB naive, early pregnancy, as long as she's okay taking 2 pills, and that is definitely worth asking, because I give my patients what they will take. And if they're not going to take a big pill or not going to take 2 pills,
Right.
I'm not going to go there. And similarly with the darunavir option, if somebody we're talking about twice a day, probably doesn't, that's not optimal. So I think the Descovy-Tivicay, I will say that I think a year from now or so, we're going to say bictegravir, but we just don't have that information. And just so people know, we kind of have a double standard in pregnancy. If you come in on a drug, with rare exceptions, we say stay on it. And that's how we get information these days, because the pregnant women are not in the clinical trials. That's how we get the information about, is it safe? Because we have a national registry, and a lot of us submit our cases to the registry. I'm in the process of filling out our forms for our registry. We had a little bit of a glitch, so it's for the last 2 years, and I would say probably 70% of our patients are on Biktarvy, come in on Biktarvy, or for some reason we put them on Biktarvy in pregnancy. If they're beyond their first trimester, I have no hesitation in using Biktarvy. Is that in the guidelines yet? No. So Descovy-Tivicay, that combo is probably I think the most accepted, but the guidelines are guidelines. They are not rules.
Yeah.
And I really think that needs to be emphasized. And so when you see the preferred or an alternative, that's for ART naive, like this patient. But one thing that I would love to bring home to people is someone comes in and they've been on a regimen for a while and they've done well on that regimen. And then you look at, oh, preferred, it's not on the preferred list. That's for naive patients. Do not change a regimen that is working well.
Right.
And I often will get patients whose docs have just changed them and they're suffering. And it's like, and I then have to go back and say, you know what, we really could go back to the one that was working for you. But my doctor I've had for 10 years, he told me, no, this wasn't safe. And it was like, how do I undo this? And so sometimes I'll just say, okay, let's wait till beyond the first trimester, and then you can go back.
So let's go through this a little bit more. Let's say
Okay.
the patient comes to you already on cobicistat.
Okay.
Curveball.
Okay, no, that's fine. And so that's a great shared decision-making situation. And I think there's a spectrum in terms of how clinicians deal with this. And we know that the levels of drug that are associated with cobicistat are lower in the third trimester. And sometimes it is clinically relevant and sometimes it's not. And so if somebody is stable on something with cobicistat, I will say to the patient, here, this is where we are. We may, if you want to stay on, which is fine with me, we will just check your viral load a little more often, probably monthly during your second, third trimester. If you say, no, I don't care, then, or I don't want to have to deal with all that, then we might switch them. And so I think there are some docs who will switch people just pretty automatically early on. We have tended to say, I don't want to rock the boat. This is working well. And I've had patients, I'd probably say majority have sailed through without any change in viral load. I've had a handful where we see the viral load starting to creep up. I had one, now that patients can see their results often before I can, patient calling me saying, I think we need to change.
Yeah.
So.
We've got a few more cases. I just want to make a few other points and we might move on from the topic. Number one, efavirenz had the same problem with neural tube defects as dolutegravir did several years ago. It seems to be related to folate. So I think every woman who's pregnant ought to be on folate. Do you agree?
Yes, but realize that they really needed to be on folate before they got pregnant.
Right. Okay.
Because the
So
neural tube is fully formed by 6 weeks from last menstrual period.
correct.
And that's when most women find out they're pregnant.
Yep. And
So-
then when you use a multivitamin, one of the questions that came up, can you use an integrase inhibitor and still use a multi? Yes, you can separate them about 12 hours and that usually gets around the problem. Steve.
Can I ask you about since we're rolling out CAB-LA, rilpivirine, if a woman is pregnant and controlled and becomes pregnant, what is your approach there?
So we're waiting for that case. And this is the entire perinatal guidelines panel has been debating this and struggling with it. And there's been a movement toward, oh, I would switch them. But then somebody else says, but the effects of this are lasting for so long. Are we putting them on a double regimen? And I think we're going to move toward stay on and see what happens, but we don't know. And that's a great question. And we know it's coming this year.
Yeah. And the thing to watch therefore is if it's not injectable or whatever, that fan acids are going to be used or H2 blockers, proton pump inhibitors, and the rilpivirine gets into trouble a little bit. Okay. The great discussion. Thank you. And someone asked on the thing about TAF. Yes, TAF is actually in one of the studies viewed to be get the nod over TDF in this setting. So TAF FTC dolutegravir or TAF 3TC dolutegravir, which you can get as a single dose tablet in sub-Saharan Africa and other places, is a great thing. And by the way, the cost of that, of sort of TDF 3TC dolutegravir internationally, one tablet once a day for a year, is about $30. I'll let you think about that. Okay, how do I simplify a complex regimen? This is something we see a lot of. It's a complex stem here, but basically 24 years ago diagnosed, started on a bunch of different regimens, now is on dolutegravir, boosted darunavir, TAF FTC, and you don't have access to resistance data. Everyone ever seen a case like this? Mm-hmm. Yeah, we do. So would you stay the course and not change the regimen, or could you simplify to dolutegravir or bictegravir or some other boosted protease? Go ahead and vote. And this is pretty complicated. I can make it more interesting and say the patient's tired of taking a handful of pills for breakfast every day and would like something simpler. So let's see what the group wants to do. So a lot of people would change. Steve, let me go to you on this. What would you do?
Yeah, well, this sounds a little bit like a confession, but we have used archive genotyping in this setting to kind of look and see if there's a lot of NRTI resistance or something else that might help make a decision. I say it's kind of a confession because we don't really have, clinical trial data that shows the benefit of the approach, but it seems intuitively to be a good tool. And so I might use that information to help simplify.
Joe?
I agree with Steve. I also think, could you go back to to the regimen again?
Sure.
Oh, yeah. So I think what we were seeing a lot of several years ago was the switch to the newer integrase inhibitors as the backbone, and we didn't have as much confidence with them in terms of their ability to suppress, and we were adding frequently a protease inhibitor on top of it. And I think we saw that a lot several years ago. And now that we know that we have dolutegravir and bictegravir, which both have, really low barrier to resistance or high barrier to resistance and are really effective at bringing down the viral load, I think we've realized that we don't necessarily need that protease inhibitor anymore. And I think, yes, I probably would do the archive genotype, but in some cases, I'd probably just take it away.
Right. I think what we're learning is that once someone's fully suppressed and doing well, it's a different story than when they have a very high viral load and you're trying to get it down. And their archive resistance may play more of a role. But once you have it under control, it's good. There's also a lot of data now that show if there's just an M184V, don't sweat it. I mean, you might want to think about that a little bit more with dolutegravir 3TC only, although there's some data coming out potentially at this or future conferences like ID Week that may show that's okay. I personally am a little bit uncomfortable with that. If I know there's a M184V in the history, I might lean away and go more of a traditional 3-drug regimen. But I think it's worth a try. But this is where open discussion is important and a little bit more frequent monitoring, because you don't want, if there's going to be virologic failure, you don't want it to happen and then not see them again for 6 months. Steve?
Yeah, I mean, the dolutegravir is obviously a new class of drugs. So really the key here is whether tenofovir is still effective. And so provided, that person was undetectable through the other TDF containing regimens, then it probably is still intact. And then probably the simplification will work.
So there's a question just in follow-up here with rilpivirine. If they're on an injectable rilpivirine, does it matter what's going on in the stomach? And the answer is no. They can be on PPIs because the interference is with absorption from the gut. And if they're going direct into the buttock, then that's not an issue. Okay, what do I do with a patient with persistent detectable viremia, which is about 10 to 15% of my patients? So this is the same kind of guy, more or less, and he's on dolutegravir boosted darunavir 3TC. And the viral load, you'll notice, is 85, and his 6 months ago was 62, and he's never really been below 50, but he's never been above 100, kind of percolating for years. What is this? Should you change his therapy? Yes, no, not sure. Go ahead and vote. Jason, I'll go to you on this one. Let's see what the audience says. All right, about 2/3 say no. What do you say, Jason?
Well, I think we all want to achieve that perfect threshold of viral suppression, right? I'm not overly concerned about this patient in terms of, immunologic decline, but I am concerned about ongoing immunologic activation and what's causing that. So he's got clearly circulating and replicating virus. Below the threshold that should be transmissible if we're worried about potential transmission. So we're not really worried about, any kind of break-in U equals U principles. So again, I think it's a process of shared decision-making. I've had several cases that we've done ultra sequencing by Bob Silicano in these circumstances to look and see if we can uncover any, hidden mutations. And ultimately that's, a fool's errand typically when we try to do that.
Right. So I think that the key to this question is in the initial viral load of almost 1 million. And what that correlates to is a much larger, and Bob Silicano would back this up, a much larger reservoir of latently infected cells. And if you go forward to this biology picture, the antiretroviral therapy kind of operates in that lower right quadrant by blocking the infection of new cells. And that pretty much is 100% with good regimens. It's the upper right with those latently infected cells, a reservoir that can be spitting out virus periodically just on stimulation. And if you have more of them, because the viral load at baseline was very high, that spitting out is just more prevalent. And so it just spills into the bloodstream where you can detect it. It doesn't mean that the antiretroviral therapy in the bottom right on this slide is failing. So the way we know that is partly from the data that Jason said, and partly from studies that show that if you add more drugs on, the viral load doesn't budge. It stays right at 60 or 70. Connie.
I was just going to make that last point, building on this concept, is there have probably been no fewer than 20 clinical trials attempting to eliminate the low-level persistent viremia by adding some immune response modifier or something else. All of them have failed. So
Right.
as long as the patient has a good immune recovery and stays in that stable range, adding or intensifying therapy does nothing.
So that's two fool's errands on this
Right.
conversation. All right. So now to your point, what about the CD4 count that doesn't respond? Anybody had a case like that? All right, here we go. So this is a 30-year-old lady, started on pretty good regimen 4 years ago. Her initial viral load was 78,000. She came down nicely. The CD4 count over 4 years has only gone from 80 to 167. Anybody seen a case like this? Yeah, I think we all have, many of them actually. What is going on here? So is this a failure of a regimen where you would change to some new NRTI or a new PI or an integrase or maybe even add IL-2? Remember that? Hui. Okay, go ahead and vote. Yves Levy from France did that study. Oh boy. Did increase the CD4 count. Let's see what we got. All right, so most people would stay the course, and I don't know if we need to go on a whole lot further. Any comment?
Well, I think just make the point that people with a CD4 count in the hundreds that have a suppressed viral RNA have a much lower event rate of like an opportunistic infection than somebody who's got the same CD4 count and is not on antiretroviral therapy. So I use that as a reassuring kind of discussion with patients. And people that start out with really low CD4 counts are at risk for not completely recovering their CD4 count.
Connie?
And just from the clinical trials perspective, this concept has also been attempted with intensifying therapy, changing therapy, adding therapy, and it has had no appreciable effect.
Yeah.
Maybe with the exception of IL-2, which you're only treating yourself with. But I think the point here, though, there is a study that I was involved in that looked at the trajectory of increase in CD4 count over time. There have been a couple of these studies where people who started very low had an increase and they continue to increase over time. The one I was involved in looked at 6 years out in the alert cohort, and they eventually do have a rise in their CD4 count. It just, that group of individuals, very low CD4 counts, takes them a lot longer to get there
Yep.
than people who've not had that low CD4 count for as long.
So this is a diagram describing, so the green lines are what you normally see. Viral load drops dramatically and the CD4 count, especially in the first 6 weeks, really goes up. These folks, like Connie's mentioning, sometimes they didn't get that bump. But I didn't draw it great, but the slope of the line at 2, 3, 4 years is roughly the same between the green and the yellow here. So that's a different type of CD4 count regeneration or recovery, which is really slow. There were studies of rheumatoid arthritis in the 1990s where they used a monoclonal against CD4 to treat. And one dose knocked it down, but then it came back. They gave 2 or 3 doses, they knocked it down, and it didn't just come right back. And it looked just like that yellow line slope and coming back. So it's like, that's the replenishment. And I'm pretty confident without a whole lot of strong data that that first bump is really release of CD4 cells from lymphoid tissue that's attracted there and trapped there because of ongoing replication in the lymphatic tissue and elaboration of adhesion molecules like ICAM and VCAM. You stop the replication, that elaboration of the adhesion molecules drops, and you get like a redistribution of sorts that didn't happen in our patient. And about, I don't know, again, 10 to 15% of people, maybe a little less, don't have that experience. Okay, so this is the last question. We'll get to the questions from the audience here. We can do this pretty quick. How do I manage someone who has frequent STIs? Anybody seen a patient like this? Whew. Like every clinic. 35-year-old guy, followed by you, doing well with HIV, takes his medicines on Big TAF FTC, and he has a new STI about every 6 to 12 weeks. And it's almost like he just walks in and before you can examine, he just drops his pants and bends over. And you know, he knows what's going to happen. Test him, and sometimes it's 2, sometimes he gets the trifecta with all 3. And we're just constantly repeating. So the question here is, you're going to counsel him each time and say, you know, not going to do it, just, you know, but he's going to do it. Offer amoxicillin or doxy or cefixime after each sexual encounter. Go ahead and vote. Let's see what the audience wants to do. You've seen some data on this already. A little bit of controversy here. All right, let's see what we got. All right, 77%. Wow. And what are the data to support this in treated patients? There ain't any data yet. What's the concern? Resistance, right? I mean, GC, it doesn't mess around. It's going to get resistant to most anything. So, Jill, what do you think?
I mean, this is.
You ever seen a case like this?
Oh, yeah. Oh, yeah. Just like.
So what do you do?
5 on Friday. Well, first of all, with someone who is coming back with STIs over and over again, I absolutely want to make sure that their partners are getting treated. And I think that's a part that sometimes we forget about or we don't think about the same way. And when we say, you know, expedited partner therapy, and we say, you know, I'll send you an extra 7 days of doxycycline, well, it actually might be an extra 7 times 6, you know,
Yeah.
How many partners do you actually have that we're talking about? So I think that's really important. Sometimes you'll see that. You know, I think A is a totally reasonable way to do it. Just keep having the person come back. I have been giving patients take-home swabs so that if something does arise, they're symptomatic, they can do the swabs without actually having to come and make an appointment, and then we'll see what the results are. I've now done the Doxy 200 once, and it was a long conversation with the patient about the fact that it's not, you know, it's just based on some very minimal data right now, but it is impressive data.
Yeah.
I mean, the fact that you see reductions in all of the STIs.
Right.
So anyway,
So-
I haven't been doing it that much.
We have studies ongoing with this, I think. Is that right?
Yes,
Yeah,
bigger
yeah,
studies.
Yeah,
But there is the Doxy Prep.
right. Doxy
Study.
prep. Yeah, for PrEP. Yeah,
Yeah.
that for sure.
Oh,
Well-
but it included, there were people living with HIV in that study as well.
Okay,
Yeah,
good.
the reductions are really phenomenal and surprisingly big reductions in gonorrhea as well, which you wouldn't necessarily have thought. Syphilis
Right.
and chlamydia makes sense, but
Okay, so the answer is there are no data yet. Extrapolate from PrEP, the French study, maybe it would work. Concern about resistance. But it's really a harm reduction question. And the question is, what's the long-term harm? And we don't know. So if you go that route, which I actually did in one patient, made me nervous. But he actually asked for it because he had noticed it in the literature, you know, of what he was reading. And I had trouble just absolutely saying no. And he was literally coming in about every 6 to 8 weeks. Okay, let's see about some final questions here. On the chronic low-level viremia, despite ART therapy, sub-Q lenacapavir, once approved, I think it goes back to the story that Connie said, that when you keep adding drugs, it's biologically not what's going on. So I don't think that would necessarily help. Yeah, concern about resistance, absolutely, for doxycycline. We have to just wait and see, and we might get into trouble with that, which is why I think we all need to be uncomfortable, even if you decide to do it. How much does age play in immune reconstitution? Yeah.
We were talking to each other.
Oh, that's all right. No, it's just, that's okay. Talk amongst yourselves. Here's a number. Here's a question. Rhode Island. It's neither a road nor an island. Discuss. So approach. So yes, everything gets slower and doesn't work as well as you get older in general. That's a good thing to say.
No, I think there's some clinical data that older people have more trouble recovering their CD4 count.
Yeah.
If they have CD4 depletion.
Okay. And then the last question here. Should viral load less than 200 be considered viral suppression? By definition, given current commentary on U equals U. I mean, Jason, you've been you're at Hopkins. A lot of the studies, Tom Quinn and Rakai back in 2000 showed if they were in the lower group of viral load less than 1,000, there wasn't transmission, right?
That's right.
So that was the first hint that U equals U was happening. 200 is a good number for viral load for not transmitting. I think we can agree on that. But once you get above 150, I start worrying about, is there a problem with absorption? Is there a problem with adherence? Again, for blips and for low level viremia, somewhere between 50 and 120, 50 and 150, you start getting close to 200, you should start questioning whether the ARV has got a kink in the armor in some way. This was a fabulous discussion. Thank you all very much. Thanks for the questions. I think it made it go a little faster. And I will turn the podium back over to Dr. Cheever. Thank you, guys.
I just want to make one comment because pregnancy can be very terrifying to people who don't usually take care of pregnant people. And there is a 24/7 perinatal hotline out of UCSF called the National Clinician Consultation Center. And 3 a.m, you can call and you get a real human being. And they welcome questions. They're paid to get their questions. So don't be afraid that they're going to think this is a stupid question. But it is one of the most wonderful services. And I, even though I am one of their consultants, I sometimes call because I just need another brain to bounce off of. Like my patient doesn't fit in any of these guideline descriptions. And so to know that you always have a backup. And it is a really, I think, a wonderful service. Thanks.
Thank you all again.